Welcome everyone to this second installment in the distinguished seminar series from the Cambridge Centre for AI in Medicine. Apologies for the problems related to the Zoom. So hopefully everyone's received this information and has joined. So welcome. Because the centre's just opened, I thought I'd spend a couple of minutes just to describe what the centre is aiming to do before we start the talk. And so our mission statement from the Centre for AI in Medicine is to develop pioneering AI and machine learning technologies to transform biomedical science, medicine, and healthcare. And in fact, we're looking to develop interdisciplinary cutting-edge research that drives innovation both in ML and AI and allows us to transform and create a revolution in biomedicine. And so what we're looking for is to be in the sweet spot then between science, medicine, and machine learning. And we have four pillars of research within the centre: biomedical discovery, omics analytics, precision medicine, and next generation clinical trials. And for those of you that want to know a bit more, learn a little bit more about what we're doing in the centre, I can refer you to our recent inaugural event where there are a lot of presentations just to give you a flavour of the sorts of things that we are achieving and hoping to achieve. So without further ado, it's my great pleasure to introduce Professor Isaac Kohane to this distinguished seminar series. Many of you will already have heard of Professor Kohane since he has made really landmark contributions to the application of machine learning to a whole range of aspects of biomedicine. He's the inaugural chair of in the Department of Biomedical Informatics at Harvard Med School. He's developed computational techniques across a whole range of challenging problems, including whole healthcare systems, functional genomics, particularly in neurodevelopment, and the analysis of genomic data to diagnose rare diseases. He leads three NIH-funded projects, the Center for Excellence in Genomic Science, the Coordinating Center for the Undiagnosed Disease Network, and the Center for Excellence in Big Data to Knowledge. So we're very grateful to Isaac for being here. We're going to run a pre-recorded talk followed by a Q&A session. Could I ask everyone to post all the questions in the Zoom chat function, and then we will read them out and to Isaac for his comments during that session. So his talk today is entitled "Finding the Doctor in Biomedical Informatics." I've had a sneak preview. It's a great overview of some of the potential for AI to transform biomedicine, but also some health warnings about how it could be misused. So without further ado, Aaron, if you're okay to run the pre-recorded talk. Thank you.
Hello, my name is Isaac Kohane. I'm a professor and chair of biomedical informatics at Harvard Medical School. Very pleased to be able to participate in this symposium, and we'll be glad to entertain questions and engage in discussion at the end of this presentation. Now, let me share my screen. Let's see, can we do this? Let's see. There we go. So I will address today why doctors will be required, why we will need doctors to lead in the transformation of medicine by artificial intelligence, and why, if we don't, patients will suffer, and perhaps doctors as well, unless we take our own agency into our own hands. And that, as you'll see, is a recurring theme in my presentation. Quick disclosure, I'm a member of several scientific advisory boards and corporate boards, but I always like to say, because I think it's true, that my biggest conflict of interest are not my commercial positions, but rather because I am passionately biased towards findings and hypotheses that I believe are sound until they are proven unsound. Let's see if we can share some basic assumptions. I believe medicine is the great frontier for a variety of reasons for researchers and clinicians. There's a boundless opportunity to improve the quality of life, of our life on this planet. The complexity of medicine, especially as it matures, and its multidisciplinary nature fits very poorly with the current practice of medicine and the way we educate doctors and other clinicians. There are some painful institutional barriers, both commercial and cultural and academic, which are slowing our exploration of this frontier, but those are transients, and I'm confident will transform. But most importantly, medicine is at its core an information processing discipline. Fundamentally, all the transactions, the flows of data between the patient and doctor and their sources of knowledge, whether it's other patients, literature, colleagues, is all information processing, knowledge processing. And being able to optimize that is optimizing the very lifeblood of the practice of medicine. And those of you who are choosing to join us today are exactly the multidisciplinary types with quantitative skills that have the tools, intellectual tools, to mold this discipline. But again, you have to realize that you can't wait for a knight on shining armor to make it all happen. We have to have our own agency. We have to move ahead and overcome the barriers to the implementation of this program. So why is AI in medicine a fundamentally medical endeavor requiring doctors? Well, as I will hope to show you, misunderstanding medicine leads to harm by medically naive AI researchers. And one of the biggest mistakes is to distinguish, or lack of distinction, between the study of doctors and their behaviors and the study of patients and their physiology. Those are different processes, but they're often treated as if they're just one data set. Furthermore, engineering for the medical knowledge worker, that is the clinician, especially the clinician of the future, is a primary goal of our efforts, not an afterthought. And if we're not careful, there is a huge potential for misunderstood data shifts and contextual dependence of AI performance that will really upend us if we don't make sure we're aware of it in our deployments and implementations. Finally, I hope to be convincing that artificial intelligence is already present today in cutting edge applications, and we're not really at a quantum barrier. It's really just a matter of how fast are we going to go forward. In discussing machine learning, I want to make sure that we are all on the same page. In this diagram that was published in JAMA by me and my colleague Andrew Beam, a professor of epidemiology at the School of Public Health, we make a simple diagram that you see here, which shows on the y-axis the increased autonomy of machine learning models. That is, they require less human interaction, and on the x-axis, increased size of data sets, such that machine learning models that we're well familiar with, such as the Framingham heart risk model, a logistic regression equation, is one in which, as shown by this red rectangle, we're in the 10,000 range size data set, and there's still a lot of human interaction in the development of the model, such as picking which variables to study, which variables to include in the model, and how to tweak that model for optimal performance. But it is the case that in the most recent wave of neural network driven deep learning models, the so-called deep learning zone here, we're much more in the top right corner of this spectrum of machine learning. Data sets that are much larger, often, not in medicine, but often in other applications in the billions or trillions of instances. And the machine learning programs that are used have a great deal of autonomy in selecting parameters of their models and the structures of the models based on the data that's driving their development. I'm sure all of you have saw this paper when it first came out in JAMA in 2016. A breakthrough paper which showed how Google had demonstrated that detection and classification of retinopathy by a deep learning algorithm that had previously worked well in some competitions, but was augmented by Google with thousands of more cases and annotations performed at the expert level. And it's telling, but I think telling in the wrong direction, that the major involvement of doctors in this effort was simply labeling the cases, not developing the models, just simply labeling the cases as to whether they were retinopathy or not. Some at the time read this as saying doctors were going to be essentially bypassed. Since then, by artificial intelligence and neural networks. Since then, there's been a lot of backtracking. Most of it has been pious in the sense that, oh yes, we'll have these computer programs working side by side with doctors. What I hope to show you here is that it's not a pious aspiration. It's a necessary aspiration if we're not going to commit extensive harm. So for example, let's look at an AI application that was deployed by Epic. Epic is a vendor of electronic health records. And they developed during COVID a predictor based on some of their EHR data sets of hospitals they work with, a predictor of which patients were going to deteriorate, especially when resources were scarce and the beginnings of triage seemed to be coming our way. This seemed like a very important function. But subsequent studies published here in the Annals of the American Thoracic Society showed that there was poor calibration of these artificial intelligence models when they were applied to other hospitals, which had different populations, different procedures, different styles of practice. And therefore, you could not assume that the prediction of which patients were going to deteriorate was accurate when you transferred it from one hospital to another. Something that would have been obvious if you were both a seasoned machine learning engineer and with a lot of knowledge of medicine. And furthermore, what has subsequently been shown is because as COVID evolved in the subsequent months, such that there were different therapies, different presentations, different age distributions, the data set shift caused by the change in disease was totally not reflected in this model that had been developed earlier in the year. And so you should ask yourself, as we all should, if we approve these programs for use, how do we actually track them? How do we make sure that they understand the medical context that is changing underneath these programs, such that we're actually not, in this case, triaging patients into the wrong medical pathway? It actually gets even worse than that. This is, there was an analysis of laboratory values that was done by one of my colleagues, Griffin Weber, professor at our Department of Biomedical Informatics and at the Beth Israel Hospital. And he had looked at hundreds of labs across multiple hospitals, and he came up with a survival table. And so I was visited by a Silicon Valley CEO, entrepreneur, and someone who was already involved in artificial intelligence in medicine. And I asked them a simple question. Why is it, as shown in this table, that if you are, as I am, a white male between age 50 and 69, if your white blood count is low between 12 a.m. and 8 a.m., let's say at 3 o'clock in the morning, your chance of death in the next 3 years is greater than 50%. It's actually 56% and change. Yet, if this same low blood count is found between 8 a.m. and 4 p.m., probability of death in the next 3 years is less than 3%. The visiting CEO thought about it, said, is it circadian rhythm? I said, no, that's not circadian rhythm. The answer is something much more dramatic. If it's 3 o'clock in the morning and someone's trying to draw your blood, that means you're not an outpatient. It means you're in the hospital and you're very sick and your blood's being drawn because at 3 o'clock in the morning, someone needs to find out why you are deteriorating so fast and what has to be done. Whereas if it's 3 o'clock in the afternoon, that's a routine blood draw on a checkup or on a diagnostic visit. And in fact, this kind of contextual dependency is throughout medicine. And what's really going on here? What's going on here is that we're measuring two different processes. One is when doctors decide to do something, like order a test, and the other is patient physiology. So it turns out that just in this graph where you see on the x-axis, the odds ratio of death, there's a higher risk of death on towards the right, and on the y-axis, how much of the information is actually encoded regarding survival in these variables. What you see is that for something like 63% of all laboratory tests, knowing when the lab was ordered, or just knowing that the lab was ordered at all, is as, if not more, informative than knowing the value of the laboratory test. We published this in the BMJ, and of course, when you combine both the laboratory values and the what we call health system dynamics, the behavior of the healthcare system, as evidenced by the ordering patterns of doctors and the procedures, you get a better performance still. But again, 63% of the labs, just knowing that they were ordered and when they were ordered was sufficient to have maximum accuracy. So I do think that we have to understand when we look at a patient and the patient population that we're trying to develop a machine learning model on, that we have to understand that there are a number of simultaneous processes which are related to one another, but not the same. So as shown in this graph here at the bottom, there's physiology of the patient that results in leg pain, and then there's chest pain, and then there's ischemia and abnormal troponins. But this is overlaid by a physician belief of, for example, whether there's a myocardial infarction here or not. And that will have a different trajectory than that of the patient physiology. And this physician belief will be influenced by their actions. So when we look at data sets, whether we look at the EMR or telemetry data or details of charges, procedures for which money is obtained ultimately, we're actually getting different sampling strategies on top of these different processes. And therefore, when you see, for example, a predictor of myocardial infarction based on an EMR data set, it's reasonable to ask yourself the question, look, this machine has learned what this physician is doing in, let's say, working up a pulmonary embolism. So the machine comes to the conclusion that this pulmonary embolism pretty much in lockstep with the physician, but with some delay. But they're keying off of the procedures that the physician has ordered. And in the EMR data set, those orders are very clear. So how is this machine learning program going to work if we did not have a physician who was independently deciding to make orders? I think the performance would be a lot less. In some sense, the machine learning program is very much like that medical student who's following the expert consultant, and within a few seconds after the consultant decides to do something, can follow why the consultant is doing, but ahead of that the decisions of the consultant, really doesn't know what's going on. Another large problem in machine learning in medicine, it's actually a problem that's more broader in machine learning, but it's not sufficiently recognized, and it's quite rife throughout medicine, is the inappropriate use of case control studies. These are retrospective studies where you take a study sample and controls, and then look back in time to assess an exposure, and then you see if you can predict accurately from this retrospective group who would end up in cases and who would end up in controls. The problem with this approach, which is again the basis of thousands of such studies, is that it assumes a particular model of when the transition happens from the disease to the non-disease state. If you're doing a cohort study, for example, you would really be looking at multiple regularly spaced sampling points. But in these retrospective case control studies, you typically take the cases right when they're being sampled, and you take some retrospective, and then you look back in time, and then you find some controls matched against those cases back in time. But in doing so, you're missing what is the model of the transition from non-disease to disease state. And so, for example, we looked at a very nice study done by Pare et al., I think it appeared in Circulation, about how the risk of myocardial infarction changes as a function of lipoprotein A concentration. And they described an odds ratio that, based on the way they analyzed data, seemed fairly sound. But what they did not take into account was, in this retrospective case control analysis, very much in the spirit of what I just showed you before, they did not know what the trajectory of the LPA was in the lead up to myocardial infarction. And so they really could not estimate accurately what the real odds ratio would have been if this had been done prospectively as a cohort study. And so we tried to simulate this by, for example, using different trajectories, a linear, a logistic, a logarithmic trajectory. And we found that compared to the baseline, compared to the numbers that they listed for the observed effect, there were far, far smaller effects, which tells us that they made an assumption around the study, which maximized the study effect, which would not have happened if they had a cohort study. But of course, a reasonable question can be asked, well, how do we do cohort studies? It's already so expensive. How can we use all these data sets to avoid this kind of temporal bias? And the answer is that we have to start simulating prospective deployment as a cohort, where we actually sample over time and not do this one step back in time matching. And if you look in our machine learning literature, there are hundreds, if not thousands, of such studies, which probably means that many of them overestimate their accuracy of prediction because precisely of this flawed design. Now, such flawed designs and other flaws can not only be generated by machine learning, but sometimes are generated by human beings, and machine learning can then identify errors. So case in point, hypertrophic cardiomyopathy, a disease that is well known to the general public because it's caused very public deaths on the basketball court of several basketball athletes from sudden death. It's a rare disease. Well, it's a rare to common disease, 1 in 500. It's autosomal dominant. You only have to have one mutation, not two copies of the mutation to have the disease. And indeed, it's associated with sudden death. Several proteins coded by genes have been identified that cause this hypertrophy that is characteristic of this disease. And when we try to use machine learning methods to sort of estimate how many we should find, how many cases we should find in large exome cohorts, we found that we should find 1 in 500, and we checked against the genomes, actually exomes, of these individuals in this National Heart, Lung, Blood Institute study. And we found that there were far more cases than we would have expected. Well, why is that? Well, when we looked at where the mutations, the putative mutations, pathogenic mutations were, we found that they were way overrepresented in African-American populations. So this disease, which is said to be 1 in 500, the mutations that were said to be autosomal dominant were present in this, as you see on this chart, 25 or more % of individuals, 15% of African-American individuals, 5% ridiculously high. So what was going on? To make a long story short, what was going on was that the original studies had not obtained appropriate controls. That is, although the controls were of European ancestry, the cases looked like they were mostly of European ancestry, but several of them in Paris were of North African origin, and some in the United States had ancestors that were originally from Africa. And so this meant, although the investigators who published the original papers did not realize it, that these variants, which were said to be associated pathogenic for this disease, were in fact just common variants in African-American highly diverse gene pool and not at all pathogenic for this disease. And this had real implications, as we published in the New England journals more than 5 years ago, that in top clinics, several patients were diagnosed with hypertrophic cardiomyopathy, with all the fear, invasive procedures that would not only affect the proband, but all the family, because it's autosomal dominant, unnecessarily. And in fact, it would have only taken a few handful of African-American controls to allow it to be clear that those variants that were being detected were not anything to do with hypertrophic cardiomyopathy, and instead just these common variants in the African population. So we did publish this, and there was a lot of attention paid, and indeed, most, not all labs updated their knowledge bases. But it is surely the case that these kinds of errors are rife throughout medicine. And it's only by the combination of machine learning over our vast genomic databases and population databases, as well as informed clinicians looking at these studies, that we're going to be able to sort out these, in this case, certainly unintended biases that were nonetheless extremely harmful to patients. There's also an issue of alignment and leadership. This is, I'm showing a premature baby, and the picture of Yao Sun, former student, now eminent neonatologist. And when he was still a student, he wrote a program that controlled, this was back in the 1990s, controlled by a simple fuzzy controller, the fraction of oxygen in the ventilator given to this child, because you want to, on the one hand, maintain oxygen saturation, and on the other hand, minimize oxygen exposure, because it's toxic and it causes morbidities such as retinopathy of prematurity. And he ran the trial, published the trial in 1997, and nothing happened. And why is that? Well, I really point the finger at myself and my colleagues. We didn't do the next step, which is say, how could we not do this? Because in fact, changing the FiO2 every minute rather than on every shift or every hour gives a far more rapid and effective weaning of this baby or babies than the current procedures. Similarly, with my colleague Ben Rice, we did a study over 10 years ago where we looked at patient discharge diagnoses. Shown here is one patient, and you see on the x-axis a aggregation into different categories of different ICD-9 codes, and the y-axis shows diagnoses in the past in those categories. And what we were able to show in this study that we published in the British Medical Journal in 2009 was that we could predict across patients in Massachusetts who, in a state where doctors are mandated and do ask patients if they feel safe at home, we could predict domestic abuse on average 2 years before the healthcare system was aware, and up to 6 years earlier. It's 10 years later. Is anybody running this algorithm? No. The signal was so clear, is so clear. Why are we not doing that? Well, again, I'll point the finger at myself and the healthcare system. We are not organized so that when we can, in fact, use machine learning to predict and intervene, we don't have the leadership in place, but we could actually arrogate that leadership function to ourselves. And that's something we have to get over collectively. Let's take a little tangent into autism. So with my colleague, Dr. McMurray and Dr. Weber and several others, we put together a distributed query network across a bunch of hospitals in the United States to study autism. And in the study that we did, I think in 2011, we found that there was a lot of medical comorbidities that were not well documented in the literature for autism. And in the study that involved tens of thousands of children, we found that, among other things, gastrointestinal disorders were highly overrepresented. And remarkably, within the gastrointestinal disorders, inflammatory bowel disease. When I brought this to the attention of a developmental medicine specialist, and I should say by training, I have a PhD in computer science, but I also trained as a pediatric endocrinologist, not a gastroenterologist. So when I asked the gastroenterologist, what's this with the increased inflammatory bowel disease? They said, it's not a real diagnosis. And one expert told me, I quote, brain bad, tummy hurt. So I have to say that irritated me. And so we doubled down. And with a colleague of mine, who's now a professor at the School of Engineering and Applied Sciences at Harvard University, Finali Doshi, we did a study where we looked across a 15-year span from birth, all these kids, where we divided up into 6-month segments, these children's lives. And within each 6-month segment, we would note with a 1 or 0 whether they had one of thousands of comorbidities, most of which were rare. And then what Professor Doshi did, she was at that time a postdoc having just completed her PhD at MIT. What Professor Doshi did was to cluster these patients so that patients who had similar comorbidities at similar times would come together. And what she found was fascinating. There were 3 groups of patients and then a fourth larger group that was less defined. And these 3 groups of patients showed, there was one group that is just autism with mostly seizures, another group of patients who have autism and mostly psychiatric disease like schizophrenia, ADHD, depression, and a third subgroup which had autism and immune-related disorders like infections, sinus infections, ear infections, lung infections, and autoimmune diseases like type 1 diabetes and inflammatory bowel disease that we verified clinically that they in fact did have. So it was real. And so I can tell you that dozens of parents came to me personally to thank me for doing this study because we showed that their kids were part of this subclass that machine learning showed was consistent and robust, that was completely opaque to the clinicians who had seen these patients but could not see these subgroups by virtue of their human inability to really systematized across thousands of patients. In the interest of time, I'm not going to go into detail, but we've continued to explore autism in subgroups. And most recently, we published a paper led by Alal Iran, the professor at Ben Gurion University in Israel, and a former student of mine, a paper in Nature Medicine where we showed that using a combination of expression differences between males and females in the developing brain, differences in frequencies of rare variants in cases versus controls, and then looking at families across hundreds of thousands of families in large healthcare insurance databases, we're able to identify a new subgroup of patients with autism who specifically had lipid disorders that appear to be causal to their disorder. The point I make here is that clinical discovery in medicine is going to be vastly accelerated by our ability to look across these large databases. And in that respect, I should say the UK Biobank has been an absolute world leader in showing us the way. One of the least pleasant aspects of the effects of informatics on medicine has been that of process automation using electronic health records. By and large, these have caused doctors pain, suffering, boredom, despair. And there are a variety of reasons for this. I will cite two. One is because administrators are driving the specifications of what is being maximized by these electronic health records. And the second is that doctors soon were no longer part of the design of these systems. When Octo Barnett, back in 1966, did the first mumps-based electronic health record system, it was wonderful. It was a wonder for its time. The same mumps-driven systems in 2021 are not wonders. And they're making doctors leave medicine, and they're making doctors spend less time with their patients. But that's why I believe those of us who are in medicine and who are looking at machine learning and artificial intelligence have an incredible opportunity. As described by with my colleagues at Google, Alvin and Jeff Dean, we focused in a review article in the New England Journal on the various ways in which machine learning could transform medicine. And one of the most important ones was in the use of machine learning to act as if it were a highly educated, highly conscientious, very aware medical student who would follow around the doctor or clinician, see all the measurements made, see all the physical exam, see all the procedures ordered, hear the interactions, the verbal interaction between the doctor and patient, hear the doctor summarize the patient visit and give the patient and the plan for next steps and the ancillary personnel, what the plan would be. And this automated version of this exaggeratedly perfect medical student would then generate a documentation of that visit with multiple versions for different audiences, whether for the patient, for the doctor, for epidemiology. This without forcing the doctor to be a data entry clerk. I hope this doesn't sound too fanciful. And even if it does, let me assure you, the technology is very ripe to do this. And the only thing that will stop us from doing this is the ambition and our ability to convince leadership. One of the most exciting areas of medicine is clinical genomics. When you look at an entire genome how do you know, out of the many variants that are present in all of us, which ones are disease causing? Turns out that's a hard problem. I'll get back to that. We were all very impressed when the engineers at DeepMind were able to develop programs which could master Go and chess using reinforcement learning, essentially having the computer play itself for millions in games. And the question was, could this become the model of medicine in the future? In other words, could we get this world-class expert playing in medicine, just as we could get world-class players in Go and chess? So it turns out that there are certain specifications for what you need to have in a system in order to be able to effectively deploy a reinforcement learning architecture. One is that the system should be deterministic. Second, that it should be fully observed, that the action space is discrete, not continuous. Access to a perfect simulator, the game itself. Each episode or game is relatively short, and the evaluation is clear, fast, and allows a lot of trial and error experience. Now, all these attributes are not true of medicine. Physiological and disease course and drug response and surgery are neither deterministic, fully observed, or discrete, and we don't have perfect simulators, among the many things that are lacking. But there is a part of medicine that will, in fact, respond, that does, in fact, meet these criteria, unfortunately. And it's the game of reimbursement and administration. So there are rules, bureaucratic rules that can be learned, and we can observe and play these games millions of times to actually figure out which are the best ways to game the system to maximize income. That would be sad if that was the way that AI was used most successfully in medicine, but it is going to be the way if doctors don't get involved. If we really want to go to the light side of artificial intelligence implementations, we'll have to make sure that we focus on things like that matter, such as augmenting doctors' advice, providing patient support, reflecting the utilities of patients in the decision-making process. But that will not happen if we don't take leadership. So going back to the issue of pathogenicity, how do you do that? How do you go through millions of variants that we each have and figure out what's the one that's likely to cause disease? Well, I'm glad to say we have our AI programs, machine learning programs working on this today. So, for example, we had this patient who had worsening dystonia. By age 5 or 6, they were not walking, not speaking. And we had no idea why. They were referred to a network that I happen to be the principal investigator of, the coordinating center, the Undiagnosed Disease Network. And they were seen, their blood was taken, their genome was sequenced. And using these now fairly widely used machine learning programs, a small list of variants were prioritized, which were thought to be those responsible for the disease. And in this child, turned out to be a mutation in GTP cyclohydrolase 1, causing a deficiency state. And this gene codes for a protein that is involved in the metabolism and the generation of neurotransmitters. And because there was this insufficiency, the child was suffering from a steady depletion of these neurotransmitters. And yet, when we gave this child L-DOPA, folinic acid, and 5-hydroxytryptophan, the precursors that to the neurotransmitters that were not being generated because of this deficiency, this child started talking and walking within months. So that's quite remarkable. And we've done this actually thousands of times, well, it's not hundreds of times across thousands of patients for which we've received applications across this network happening that shares data, genomic and clinical, across these 12 healthcare centers in the United States. And although it's right now still a research project, the fact is it could be easily reduced to practice if we took these algorithms and embedded them into the daily evaluations of patients who have been refractory to diagnosis. I should note that a third of the patients who have been referred to this network already have had genomic sequencing done, just that the genomes have been incorrectly analyzed, because in fact doing it right is important and is not yet something that can just be done by perusing the genome and picking variants that some individual clinician thinks is relevant. I want to close by talking about adversarial attacks on medicine and machine learning. So adversarial attacks are actually not a new thing. We know that when in the United States, patients are seen, doctors will diagnose patients, and those billing codes are then reviewed by a team of individuals in some basement in the hospital, and these codes are then optimized to maximize for reimbursement. At the same time, there's a team on the other side, the payers, who are looking at these codes and are trying to figure out what's really going on with the patient and what is the right amount to pay. At least those attacks, although adversarial attacks, although they are sinister, are fairly obvious. With the development of convolutional neural networks, we may be overly complacent about the performance of these networks, such that we don't have the awareness that we should of the possibility of adversarial attacks. This piece that we published in Science last year, led by my former grad student, Sam Finlayson, we showed that for a variety of machine learning applications, as you see here, initially this lesion on the skin is diagnosed as being benign. By adding some specially designed noise, understanding the workings of the algorithm, we get a picture that looks pretty much the same as the original picture. But then the algorithm now diagnoses this patient as having a malignancy. Think about the ways this could be used to change billing, to change the percentage of patients who respond to a drug in a trial. And notice it's not human readable in its difference. And there's two messages here. One, that these adversarial attacks are not only possible, but are not obvious, but also that these neural networks, these artificial neural networks, do not see things the same way that we do. And I think that begins to tell us something about the possibility of brittle behavior in these systems, going on along the lines of the data shift that I told you about earlier. They are very vulnerable to this contextual data set shift that's unintended, and certainly very vulnerable to this imperceptual adversarial attack. Whoops, sorry about that. I just want to close there, and I want to thank you for your attention. I want to advertise that we are holding our Symposium on Artificial Intelligence for Learning Health Systems in Bermuda this October. We have already had a pre-symposium which you can visit online. Thank you thank you very much for your attention.
Thanks very much, Zach, for a great talk, very stimulating and actually provocative, I think. So not only highlighting the opportunities and excitement around AI, but also some health warnings about applications. Can I just remind everyone to post questions on the chat, and then I'll read them out. Zach, are you unmuted? And
I am. So are we going with plan A, which was to go to another Zoom? Or?
So, yeah, so what we'll do is for this open session, we'll carry on with the Q&A here.
Yeah.
And then when this finishes, we'll go to the other Zoom meeting, if that's okay.
That's fine. So I already saw it's actually a true COVID 2020, 2021 experience to be able to speak behind your own back in the chat. So I enjoyed that. But I'm going to allow you to decide which of the threads, if any, that are already ongoing in the chat where we will pursue in public, or whether we pick up additional questions.
So Zach, maybe I can start with a question from Mihaela, which was, I guess, around kind of horizon scanning. And her question really is moving, imagining the next 10 years, what are the big breakthroughs in healthcare medicine do we expect to see that are going to be empowered by machine learning and AI?
So I think I foreshadowed some of the answer in the chat, which is we indeed have had massive revolutionary uptake of technology where it's mattered a lot, such as imaging that obviates the need for a scalpel to make a diagnosis, like MRI, which after all, in addition to the magnets, is a huge amount of computing for deconvolving the signals into an image. And I believe there are a number of tasks where doctors, despite whatever arrogance we have, will immediately concede that the computer has superhuman capacity compared to themselves. And so I gave one example, which is an undiagnosed disease network, prioritizing across the literally hundreds of thousands of private variants that we have, or even common variants that we have in our genome, to understand why we have disease, or why we have a particular variant of a disease, or a particular subphenotype. That's going to be, for the foreseeable future, driven by computing, and therapies for there. We can see in the era of gene editing and use of oligonucleotide therapies, figuring out which portion of the genome to treat, to edit, and designing all those reagents is all going to be, I think, driven by computing and machine learning techniques. So that very clearly, I think, is one area. So the whole area of genomics and hyper-individualized medicine is something that no medical student, as ambitious as we may be, could ever conceive of doing. The other is, I think, brought to mind by, but it's less obvious that it will happen, which is, will we learn from our disastrous experience globally with the pandemic and actually create a machine learning global infrastructure that can track well and have intelligent models of what's going on and what to do next? It's very clear, I think, to all of us that all our epidemiologists basically blew it. They made economists look smart by comparison. And so, you could literally find a model from a well-reputed epidemiologist to point in any direction you wanted throughout the epidemic. And still, by the way, even now, you can still see people who have not only differences in the magnitude of the trend, but in the direction of the trend. So we'll see if those who are saying that we're going to see a fourth wave, or just saying for reasons that are not completely obvious, it's going to decline. So yes, in that public health arena, that might be a big pickup. The third area, which is less dicey, but if it gets past a critical inertia, I think it will be dramatic, is AI that changes the physician experience. The physician experience using EHRs has been dramatically stifling and unhappy and career-ending for some experience for doctors, and certainly a suboptimal experience for patients. And I do think it's more than just a fairy tale to say that we will be able to use multi-voice recognition, motion recognition, to not only track what's going on in the visit and document it, but also hear, as if you were a medical student, hear the attending, the consultant speak out loud what their assessment is, what the plan is, put that into a natural language compliant summary and plan that can be shared in different levels of sophistication with the patient, with the billing agency, and with the other doctors. I think that's going to change the nature. And I know it sounds politically correct, but I believe that once we'll have a few instances of it, all doctors would want it, which is really returning doctors to what they enjoy most, which is that patient interaction.
I couldn't agree more with that bit. I'd like to pick up on, there's been a bit of chat on it, but Ari Erkele's first question, which is, I guess, around the points that you made about biasing in the nature of observational routine data. And I guess there's two questions that he poses. The first is that he would argue that clinicians are biased, which I think we'll all agree with, in similar or even worse ways. So question one is, can we ever be sure that the expert oversight of an AI algorithm design is robust? And secondly, which I think is a really interesting question, can we flip this argument around and use technology to observe biases in the way we behave as clinicians?
Right. Well, this is obviously a heavily overloaded discussion, but I would like to answer it in a way that suggests that the answers are not that obvious. And I'll say that some forms of bias are good. And so, for example, the example I showed where the low blood count, white blood count at 3 o'clock in the morning is associated with a very poor prognosis versus the white blood count on the same person at 4 o'clock in the afternoon. To most machine learning specialists, the difference would look like bias, actually. But that bias is coming from the contextual understanding that the doctor has of what the patient's going through at 3 o'clock in the morning versus 3 o'clock in the afternoon. And that capture of context is, in fact, bias of a positive sort, because it's actually adding knowledge, prejudicial knowledge about what's happening to the patient in a way that's not captured by the machine learning expert. And in fact, I can't remember if I said this during the presentation. I presented these facts to machine learning experts from Google, from venture capital companies. They had no idea why there was this difference. And so there are places where bias is good. And to the extent that we have well-intentioned humans, which some of us are, I would argue that there are actually biases which actually improve the health of our patients, and that it's not clear that we want to completely de-bias the performance of our algorithms. The question is, we want to reduce harm. And so bias itself is not necessarily an evil thing. It's bias that leads to harm that is what we should worry about. And I try to summarize in my chat that I think there are such gross harms that are being done just through sheer ignorance that we're better off going for those big targets than after small targets. So for example, in that paper that we published in the New England Journal about the cardiomyopathy variants, that in fact were just common variants in African Americans. Just because we, not me, but as a medical profession had stupidly had very, very white controls. And it was actually politically correct. They were trying to match the controls to the cases. But of course, they could make sure that the controls were white, but because they go to a certain neighborhood. But if you had in Paris a white-looking individual who had an Algerian grandparent, that would be an influx of variants that were common variants in Africans that would never be seen in whites. And so if they just passed out during, or had slightly thicker ventricle, they'd be put in the cases group. And because of those white controls, those variants would be seen as pathogenic. So that's gross, despite best intentions, gross mishandling of patients, putting in defibrillators, scaring the hell out of the families. And so I would say that we have so much room to work in the do no harm category that I'm less concerned about getting rid of all sources of bias. And to return to my original point, someone's bias might be my well-intentioned, well-informed prejudice.
And the second point, just briefly, I mean, do you see a role for AI in policing or alerting physicians to erroneous decision-making? Meaning understanding the decision process, prompting physicians to reconsider based on decision-making. Do you see that as a potential for AI?
So I don't think that our AI is going to be quite good enough in the next 10 years so that I would want to have a direct in the loop kind of critique that way. Because again, AI is very brittle, as shown by the adversarial attacks. It doesn't see the same way we do. And so I think it might be appropriate more at the policies level so that a department chair could see that one of the consultants is actually behaving in a way that's just not optimal given the patient population they're seeing, and then have a discussion with them.
Yeah.
I would see that just because I think we have to recognize the big gap between what we hope AI will look like and what it's likely to look like for the next 5 to 10 years.
Can I just extending that a little bit? There's another question coming through, focusing on the adversarial attack issue that you raised, and I guess the questions are around mitigating that potential. Do you see this as an area for legislators to get involved with, I guess, both in terms of data quality assurance, but also perhaps for AI engineers to find ways to minimize or to use more than one algorithm in an orthogonal way to try and prevent? How do you see that panning out?
Couple ways. Well, first of all, I am someone who has sneered at every mention of blockchain for the last 5 years, but this might be one area where it actually might be useful. In other words, creating a digital certificate along every way so that you know that there was not the image was not messed with. Because again, just looking at an article we published in Science, those images look identical to a human, but we got the algorithm to change its diagnosis 180 degrees. And you can imagine if we're running a trial, we wouldn't just changing 180 degrees might not be necessary. Just changing, slightly more positive outcome makes a trial work. And so I think assuring integrity of the data has to be something that needs to be baked in both by law and by the manufacturers actually of the equipment, so that from image acquisition to diagnosis, there's a full chain of possession digitally secured. With regard to the legislation, I think that there will be questions which algorithms actually constitute approved behavior. Yeah. You can imagine some algorithms not being well engineered with the best interests of the parties that we want to benefit the most, namely the patients. And so I think having the regulatory authorities ensuring that what these algorithms are optimized for is the patient is one thing. And the second, but it relates to I think a deeper issue, which is even more problematic to me, which is medicine's always changing, and this results in the data set shift problem, which I think is actually even worse in the near term than the adversarial attack problem, because without any malevolence whatsoever, medicine changes all the time. And just looking at COVID, the fact that we had different treatments within 6 months meant that all our predictors of severity and evolution of the patient those models were dramatically wrong by 6 months later. And yet, had we approved them and said we were going to triage patients on that basis, we would have harmed patients. So data set, I think, figuring out how regulators deal with, unlike a drug, which more or less is stable with regard to physiology, these predictors and classifiers and triage drivers are actually pretty dynamically unstable based on the change in the practice of medicine, the change in our patient population mix, the change in evolution of diseases.
Got it. So I'll take another question. This one from Rachel. There's a theory that ADHD is to ASD. I guess that's autism spectrum disorder. What Asperger's syndrome used to be to autism. What's your opinion on this theory? And I guess, yeah, exactly.
So I was privileged to be on the National Academy of Sciences committee that wrote this precision medicine report. And when we wrote the precision medicine report, it was widely misunderstood to be about genomics. But what really we're talking about was a multi-axial classification of disease. And autism is a great example for a variety of political and financial reasons. It's been kept as a relatively indistinct bag of individuals who have a wide range of clinical manifestations, all the way from, unfortunately, nonverbal individuals who will never be able to live independently, to super high functioning individuals who are leading some of our academic departments. And so it should not be surprising, that if you look at the data, you see subsets of patients who actually look like distinct diseases. And the metaphor I give is, just like in the 17th century, all heart failure was dropsy, and all dropsy was treated with digitalis, for example. In a few hundred years later, we know that there's valvular disease that causes heart failure, that there's atherosclerotic sources of heart failure, that there's genetic sources of heart failure, that there's viral sources of heart failure. And ultimately, those actually need different treatments because they're different mechanisms. And they both overlap and are distinct. And sorting that out is, I think, helped by big data sets. It's helped by machine learning. And these monolithic diagnoses like autism or diabetes and insulin resistance are examples of diseases that right now we treat as if they're monolithic. But basically, because we treat them as if they're monolithic, it's like we're treating heart failure like it's dropsy. It's only one source. And second of all, by looking at genetics across an entire heterogeneous bag of diseases, as autism is, we actually are underpowered because we're looking at a very heterogeneous set of diseases rather than looking at a set of mechanisms. And so with regard to ADHD, I think there's a subset of individuals with autism who basically have this combination of neural circuitry that has an effect on emotional intelligence and on ability to process information in a way that reduces distractions and decreases focus. And I think that's one unitary set of mechanisms, but because of the way the medical system is driven, and because of the way we've both on the science end and on the clinical end resisted really unpacking it. And that's been actually one of my long-term goals, has been to unpack autism in this way. And by the way, parenthetically, I have a PhD in computer science. I'm trained in pediatric endocrinology. I never had as many grateful parents as a pediatric endocrinologist as I did as a data scientist, when I acknowledged to these moms who came to me in tears thanking me that these syndromes that they had were actually distinct diseases. So I don't know if I said it, but there's kids who were having abdominal problems. And in fact, if the kids could have been verbal, they would have cried in pain and said, I have pain in my tummy. But in fact, what happens in pediatricians throughout the world, if you have a child who's nonverbal and they act out unfortunately, it is the case. A lot of them get put onto antipsychotics, which do nothing for the pain. They just silence you. And so I think I've gone a little bit far afield, but suffice to say, yes, I do believe there is a subset of autism that is this ADHD, emotional intelligence subset, but it's just one of several autisms.
Got it. Brilliant. We'll take one final question then. So how do you, this is from Hadi, how do you see in silico modeling, e.g. the mechanics of arteries and the heart, helping AI make more robust decisions?
So that's an excellent question. And unfortunately, so I got my PhD in computer science and working in artificial intelligence during the 1980s. That was an era where we continued to be very optimistic about the power of mechanistic models. And I think that our experience has shown that these models are not very good at prediction. And they're always less sophisticated, less robust to noise and to individual variation than we would like. However, they may actually be more useful in providing explanatory justifications for a particular prediction, or perhaps testing the robustness of a prediction using the filter of the models. But having the models be in the driving seat, unfortunately, is an overestimation of what we can do in medicine. There was a program called Human, developed by a guy called Coleman back in the 70s, based on taking all differential equations from Guyton's physiology. And it was created a very good simulator that was good for education. But in terms of diagnosing anything or predicting anything, just did not cut the mustard. And I have to say, I've seen several companies that started in a sort of numerical simulation and really detailed simulation that have transitioned to more statistical machine learning approaches, because just those happen to be more robust. So it's something that we all aspire to, because then medicine would look more like physics. But I would argue that medicine is now still in a pre-Keplerian era. We don't even forget the Newtonian mechanics. We don't even know the orbits of most of the entities in medicine. And I think it's important to have that humility as we approach the matter.
Great. Brilliant. Well, Zach, thank you again for a terrific talk, great discussion. Thank you all, everyone, for joining in. So, Zach, we're going to move to the other Zoom for our thing. Thanks, everyone, again for their attention, and look forward to seeing you at the next session. So, thanks again.